Hello, I'm Dr. Chris Fry. I'm the Surgeon General's sleep medicine consultant, and I'm very pleased to present the sleep triad arm, something I'm very, very excited about, and hopefully we can roll through this so that you can understand a little bit about what adequate amount of sleep is. And one of the main things that in the past that we've noticed is that the Army way is we're just going to drive on. And we really understand now that loss of sleep leads to a significant decrease in performance, not only on the battlefield, but also in our daily lives with the jobs that we're doing. So what are some of the main consequences that you're going to see as you have different amounts of sleep loss? On the left-hand side of the screen, you can see the very immediate effects. If you do not have an adequate amount of sleep, even for a short period of time, and what's adequate amount of sleep? Consistently less than 7 to 8 hours, you're going to have impaired operational readiness. And so it is very important as leaders for us to recognize this and then fix these potential decreases or chances in which we're going to have these immediate effects. You know, when we say operational readiness, what you see there is that really the ability to make mental, cognitive decisions really goes down significantly. And then also, and some of you may have experienced this as well too, is that impaired alertness. And so if you can't stay alert, then you may have difficulties being operationally effective. Really, when we say one night of insufficient sleep, it is unique to each person. Obviously, if you get zero sleep for an entire night, then you're going to be impaired. That is undeniable. But over a period of time, including multiple days without adequate amount of sleep, you're going to end up getting the same as that sleep debt accumulates. You're going to actually end up getting the same effects as if you had an all-nighter and you didn't get any sleep at all. One of the things that is also very common is that you may not actually be aware that you are sleep deprived or you're not making the best decisions. And so that's why it talks in there about insidious. Kind of alluded a little bit to the accumulation of sleep debt. So if on a daily basis and over a period of time, if you continue to not have enough total hours of sleep, then sometimes the mood changes, and actually that's usually the most common thing. You get a little bit grumpy, maybe not as pleasurable to be around, and that kind of goes along with being able to resolve conflicts with coworkers and to be able to lead appropriately. Over a very long period of time, so kind of as it talks about the mid or long-term associations, and we're talking about years of chronic sleep debt, we know that that actually directly leads to exacerbations of a number of not only psychological but also physical disorders, and some of those are listed on the slide. You know what? As a healthcare provider, we'd like to think that we're immune, but this nice New England Journal study just shows that we are not. Now I understand, you can see at the very top that the original medical letters is from interns, and yes, those are brand new doctors and may not have the experience up front. And one of the things that you want to look at in this particular slide is that how many serious medical illnesses, or serious medical errors occurred in a traditional work schedule in the intensive care unit at Harvard versus an intervention schedule where they actually changed the doctor's schedule so that they could get sufficient amount of sleep. And you can see there's a significant difference in the number of errors in interns. But then slide over here to the table where it's the unit-wide, which includes all physicians, staff, residents, not just interns. And you can see that there's still a fairly significant number of serious medical illness. So not just low-level, inexperienced physicians, but the entire work crew, there's an increase in medical errors. So what does your patient distribution look like? And it's kind of upside down pyramid. And our goal is to get, obviously, everybody up to the top of the pyramid and be green. So in general, for the most part, most of your patient population is already going to be healthy, and they are normal. But then just below, as you move down along the pyramid, there are going to be those who do not get enough total hours of sleep on a consistent basis. And they're going to have a little bit of impairment. As you move along and move down the pyramid, and as we get closer and closer to sleep disorders, which is at the very bottom, there are going to be some people that do not necessarily have a clinical sleep diagnosis or a disorder, and that you're going to be able to make an intervention on and move them farther up into the green. And those are the people that typically need to change their behavior a little bit, or they just need to increase the total amount of sleep, or they just need to kind of change the way that their habits and sleep habits. So what I'm going to do is I'm going to give you some assessment tools that you can use to help try to identify a number of these disorders and then make interventions. The first one that I want to talk to you about is a very nice screen that you can use, and it's easy to remember by using the mnemonic bears. As I go through each of the different tools, I'm going to kind of point out how each of those tools are going to help you with determining when's the bedtime. Is it consistent? Do people have excessive daytime sleepiness? And excessive sleepiness means that they fall asleep when they shouldn't be. It's a pretty simple definition, but that's actually the easiest one to go with. Do they have frequent awakenings? And that also includes, do they have difficulty falling asleep, or are they waking from sleep on a consistent basis? Or after they wake up, do they have difficulties initiating sleep again or reinitiating sleep again? R is for regularity, and we know that sleep needs to be a very consistent, ritualistic process. And if there's a lack of regularity and a lack of adequate duration of sleep, then people are going to be impaired. And then because upper airway obstruction is very, very common in our population, we want to look for people that may have obstructive sleep apnea. And the most notable sign that people will have of that is snoring or gasping or choking, or truly having a bed partner say, you know what, you weren't breathing at all last night when you were sleeping. The first tool that I want to introduce you to, if you haven't already seen this before, is something called a sleep diary. And this is actually very, very helpful in determining if people have consistency, regularity, and an adequate amount of total sleep. Again, our goal is to get 7 to 8 hours on a consistent basis. It's a very simple tool if done real time. Oftentimes in clinic, I'll actually watch my patients and they'll try to fill out the entire 2 weeks while waiting for me there in clinic. It's very, very difficult to remember what you did 2 weeks ago, and so it's important to stress to use this tool on a daily basis. And I'll walk you through the example that the American Academy of Sleep Medicine here has given us. And this is just off the American Academy of Sleep Medicine site, and the link is right here, and we'll have that at the end of the resources. So for this particular example, they put the day of the week, and they said, what kind of day was it? Was it a day off, or was it a work day? And then there are different symbols, and you don't have to use their specific symbols, but you can use them as they say. So E is for exercise. So this particular person exercised at about 1 o'clock, and then they had some alcohol with dinner, and then fell asleep on the couch while watching TV. Then they woke up, and then they said their bedtime was at about 10:30, where you can see that line is. You can either just put a dash, or you can have them color it in, either one. This person thought then that it took them about an hour and a half to fall asleep, and then they slept through for about 4 hours, woke up for an hour, went back to sleep, had a couple more hours, woke up, had some caffeine, and took some medicine. Very, very simple diary, but you can tell right here there's a lot of information there that you can use to help try to determine if there's a sleep disorder or not. The next tool that I want you to be aware of is something called the Epworth Sleepiness Scale. It's a way of trying to objectify a number of subjective questions. Actually, why don't you take a second now and figure out your own Epworth Sleepiness Scale, okay? I'm not going to embarrass anybody. Keep that information to yourself. If you've already fallen asleep during this lecture, I'm sorry, you're a 3 for sitting and reading or watching TV, things like that. Okay? So as you go through, the maximum number that you have here is 24 points. And you go through and you have people fill it out. The instructions are, what is your likelihood of falling asleep under these certain circumstances? 0 is never, 3 is definitely, and 1 is kind of slight, 2 is, yeah, there's a good chance. It's a very useful tool, and we'll talk about what normals and what the numbers mean a little bit later. Another very good tool to help you, so to try to figure out if people might have insomnia, and if they have insomnia, then what is the severity? Insomnia actually can be broken down into 3 different types. Initiation, which means that people have difficulty starting and continuing to sleep. Maintenance sleep, or staying asleep, so that means they wake up repetitively over the course of the night. And then what we call terminal insomnia or end insomnia, which means that once you wake up, then you're essentially awake until the rest of the day. And as you can see there on these scales, it's 1 to 4. I never had this problem, or I consider in the last 2 weeks that this is a very severe problem. The other things that we need to know about insomnia is how it's affecting the person during the day. And these last questions, 4, 5, 6, and 7, will talk about what they think. Are they satisfied on their sleep? Is it noticeable? Does it bother them? Are they worried? Are they distressed? Are there different things that kind of go into that? And then most importantly, number 7, do they feel that really this interferes with their daily function? And that's very important. So you can see there's 7 questions. There's 4 points each, and so the maximum on this is 28. Because we know that obstructive sleep apnea is very, very common, we would like for you to use a screen to look to see if people are at a higher risk of having this airway blockage disorder. And we, as I alluded to already, people that snore, we know that they block their airway to a certain extent. Has it gone to the point, though, where it's completely blocked and has clinical significance is what we need to determine. So if people snore, we know that they block their airway. If they're sleepy, excessive daytime sleepiness, or tired, I just gave you a tool with the Epworth Sleepiness Scale that you can also use to try to objectify if they say yes or no, you're not sure. Observed, or O, of the stop bang is essentially, does someone witness them stop breathing, or what we call witness apneas? Do they have hypertension? Is their blood pressure a little bit high? Are they overweight or even obese? Well, you know that people that, as we mature and grow older, that the chances for obstructive sleep apnea goes up. So what is their age? And then we also know, because it's an upper airway obstruction, as your neck size gets bigger, now 40 centimeters is roughly 15.7 inches in size, so it's easier to remember 16 inches as kind of your cutoff as well if people aren't as familiar with metric. But as your neck size increases, the chances of having more tissue there to obstruct the airway goes up. And then, sorry guys, we're at a higher risk. So you can use those specific assessment tools, and you can then try to help your patients with a sleep prescription to help some of their problems. The first one, again, as I alluded to before, a lot of your patient population is going to be otherwise very healthy, not have any other sleep disorders, but they're actually going to be sleepy during the day. So the first question is, hey, how much sleep do they need? And over the lifetime, you can see that it changes. In general, around 10 years old, you need about 10 hours of sleep. And as you go through your teenage years and move into your 20s, then you start getting to closer to 8.5 or 9.5 hours of sleep. And then as an adult, we usually need anywhere from 7 to 8 hours of sleep. What I will tell you is if people are saying, yes, I get 7 hours of sleep, but I'm still having problems with performance due to sleepiness, then they should probably increase it to closer to 8 on a consistent basis. And consistency is very key here. So that's the first thing. Make sure that people are getting enough hours of sleep on a consistent basis. What happens sometimes, though, is that, okay, now I'm getting 8 hours on a consistent basis, but now I'm actually still having some issues. Well, it may be because their habits are preventing them from getting a total amount of 8 hours on a consistent basis. Or their habits are now doing things to fragment your sleep. So as you go through and look at this slide, the first 6 talk about some what we call very good sleep habits. It's obvious, in order to be able to be very efficient at sleeping, you need to have a very comfortable environment to sleep, meaning that it needs to be dark, it needs to be comfortable at a room temperature, and it needs to be quiet. That also includes bed partners that snore. That's very common as well, too. One of the things that you want to also make sure is that the bedroom is a place where the brain knows that that's where it sleeps, and really not much more. Okay, intimacy is fine, but it's not the place to start playing on your computer, texting, watching TV. All those things will actually lead the brain to think that, guess what, this is a place that I don't sleep. And so when you're trying to sleep, it may be confused. And so that's one of the first things that we try to do. We know caffeine is alerting. We use it for that particular factor all the time. And so by stopping caffeine at least a good 6 hours before you go to sleep, you kind of take that stimulant effect out of the equation. One of the things, too, is that we know that alcohol can make people sleepy. And some people actually use alcohol for this very reason, and times they will use it in excess. Yes, it may make you fall asleep initially, but as the alcohol metabolizes or it breaks down, then there's a rebound effect and where people end up having increased fragmentation of sleep. And then you have to get up and go pee. So all those things, really you'll want to make sure people use alcohol in a moderation and also plenty of time to let it metabolize. So for that one example that I showed you on the sleep diary, having 1 glass with dinner is probably not a big deal. Having a 6-pack before you go to bed, that is a big deal. One of the things, too, in order for the brain to be able to fall asleep as well, too, is that it needs to cool. And I'm not talking multiple degrees of Fahrenheit, but there is a slight decrease in the nadir of the body, or the body temperature to the nadir, which happens with the circadian rhythm. So you can actually use exercise to increase your temperature as long as it's far enough in advance, and we usually suggest at least 3, maybe 4 hours before bedtime. And then that natural cooling may help people fall asleep as well. It also kind of goes along with the old remedy of having warm milk. The timing is important, or a warm bath. All those things need to be done far enough, early enough, so that the body then can decrease its temperature. And then if you're uncomfortable because your stomach is upset, then that also will lead to decreased or increased time to fall asleep. So this clock on the right-hand side of the screen essentially kind of goes through all those things we talked about and all the different timing that you look at. With your goal time being the blue sleep time is probably, if we want a good block of 8 hours, 2200 to 06 is a very reasonable amount of time. For those people that you try those initial 6 sleep habits, but they're still having problems, then we can take it another step further. Okay? And these may be for people that may specifically have insomnia type symptoms. And so you've used your insomnia severity index tool, and you found somebody who's having problems initiating sleep or even falling or staying asleep. This is where we really want to focus on consistency. Okay? So when you have some one of these people, then it's very military-wise, and you want to specifically say bedtime is 10, wake-up time is 6, and the key is that is all the time, every single day. It is too frequent that we try to catch up or repay some of our sleep debt on the weekend by trying to sleep increase, but that will actually disrupt normal patterns as well. One of the things, and I kind of alluded to it, if you do other things in bed, then it kind of tells the brain that that's a place where I'm going to do other things other than sleep. If you can't fall asleep in a normal amount of time, and it's usually anywhere from about 20 or 30 minutes, laying there for 3 or 4 hours at a time worrying about or trying to force yourself to fall asleep is counterproductive. So if you can't fall asleep, then you need to get up and tell people that they need to leave their bedroom until they're sleeping. Napping can be strategically used and really the only cure for sleep deprivation is getting sleep. And so in either tactical places or other situations in which safety is very key, especially like if you're trying to drive home in the afternoon, a quick 20 to 30-minute nap is very, very appropriate. But on a consistent basis, napping is probably not recommended. One of the things, too, is that when people have difficulty sleeping, they tend to focus on time. The main reason is because that alarm clock is going to go off on a work day. And so when people focus on that, then they're actually activating their mind, and that may prevent them from being able to fall asleep appropriately. So by moving the bedroom clock or putting it out of sight so that you cannot focus on that, that is actually another very good sleep habit. I want to take a second here and talk about caffeine use because it is universal. And just as strategic napping is very appropriate, actually strategic caffeine use in moderation is also appropriate. So as you can see on the left-hand side, when you have sustained 24-hour operations and need to be alert, then there is a prescription that you can use, especially during the time period that your brain wants to be asleep, that you may have to stimulate it with caffeine. 200 milligrams at midnight and then repetitively every 4 hours is it has been shown to actually help alertness during operations. As you can see from the different examples, what 200 milligrams includes 4 Coca-Colas or a 5-hour energy type equivalent. As you go along and move down the chart looking at using caffeine, if you're not doing sustained 24 hours but just night ops, then the caffeine suggestion is just a little bit different. And then as you move down again, if you've had somebody that has insufficient sleep, again, adequate total amount of sleep is the only cure for sleep deprivation, and it should be encouraged. But if it's tactically not able to do that, then you can use caffeine throughout the day, the daytime as well. For some people, though, you're going to find that there are behavioral treatments that are going to need to be, and this is kind of stepping up some of the behavioral treatments for people that still have problems initiating and then maintaining sleep. If you look at the reference that's at the bottom, and the American Academy of Sleep Medicine has clinical practice guidelines, and this reference specifically is referencing those guidelines. And if you've heard of sleep hygiene or stimulus control, sleep restriction and relaxation training, you may have heard of those names, but you may not know how to do them. That article goes into detail on how to teach people how to do this. We know that sleep hygiene is a term that we use for sleep habits, and it can be prescribed or actually educated by multiple people. Of this list, probably sleep restriction should be monitored by a physician, because you're actually telling people for a short period of time to get insufficient amount of sleep. The idea is that when the sleep debt builds up, they actually become more efficient at sleeping, and then you slowly add total sleep time back after they've become more efficient and confident in being able to sleep well. One of the things that you probably need, or one of the questions that you may have is, okay, well, these are the things that we can try, but when do I need a sleep medicine doc? And so what we've put together here are a couple situations in which, yeah, this is somebody that a specialist, a sleep specialist, probably needs to look at. If you have someone who has persistent excessive daytime sleepiness, and so a normal Epworth sleepiness scale is 10 or less. So if you have a persistent elevation in the Epworth sleepiness scale despite interventions, meaning that they're now on a consistent basis getting 8 hours plus, and they're actually sleeping well and it's consistent, but they're still excessively sleeping, then maybe they have one of the disorders in which a sleep specialist would need to diagnose, such as narcolepsy or idiopathic hypersomnia. One of the things, though, that you also want to think about are sedating medications as well, too, and check on to see if that could be a culprit. For insomnia, the insomnia severity score, if you have a score over 15 after several weeks of attempting to fix known causes for insomnia, either behavioral health problems such as anxiety or depression, or medical conditions such as pain or chronic heartburn or things like that. If you have an ISI greater than 15, then it's very reasonable to refer to a sleep medicine specialist. Because obstructive sleep apnea is actually diagnosed by a sleep medicine specialist, those people that have a stop-bang questionnaire of 3 or higher probably need a referral up front. And then if you have people that have unusual behaviors at night, such as acting out their nightmares or actually sleepwalking, maybe they have leg kicks at night or other things that just don't seem right, then that's probably something that a sleep medicine specialist should take care of as well. So I promised you some resources. I gave them to you, and the next slide is going to kind of tell you how you can access these. All of these are accessed on the web. You can see there's a sleep diary, the ESS, the ISI, the stop bang. And then I also want to point you towards, if you have gained a little bit of interest in sleep, where you can go for more reading. Each of these websites are very reputable. They have been staffed, and those are sites that we would recommend you go look. Almost all of them have question and answers. All of them, some of them have, as in the American Academy of Sleep Medicine, have clinical practice guidelines that you can look to see the way that sleep medicine providers will approach issues such as the sleep diary, such as how we're going to approach people with obstructive sleep apnea and things like that. So those are your resources that you can use for more information. So in summary, what I want to do is focus a couple of things. And hopefully after this discussion, you've come away with, one, knowing that the brain needs on a consistent basis 7 or 8 hours of sleep on a consistent basis. Insufficient sleep is going to impair. So if you don't get that on a consistent basis, then operational readiness has the potential to become compromised. When people are actually getting enough hours of sleep, or if they're not, then you want to look at their sleep habits and review those. And the sleep diary is a very good way of looking at those habits that may influence sleep, either voluntarily or medication-induced, and you want to make sure you focus on that. Talk a little bit about it, the appropriate use of caffeine. And then finally, we gave you some guidelines on when you should refer to a sleep medicine specialist for further evaluation. Thank you very much.